in the last 2 to 3 years, there has been a plethora of data available on drugs in CRPC. In fact, they have changed the way to think about sequencing of drugs to a large extent. And what I am reviewing today is literature from as late as November 19, right up to April 20. So I hope that we will be able to give some useful tips for day-to-day clinical practice based on the current literature. So are my slides visible? Right. So when we're talking of using drugs in cancer prostate, rather than focusing only on CRPC, I thought let me just expand the scope to speak on the other clinical strata also. So what are we saying? We are today going to discuss the utility of drugs in the various scenarios that we encounter clinically. So the first scenario is M0 CRPC, which means non-metastatic, but in a CRPC state. Then the hormone-sensitive prostate cancer, which has become metastatic, or in the later stages, which is the hormone-refractory metastatic CRPC. And there we have to look at how should we start our therapy, what is our second line backup, and then even both lines failing, how should we think about therapy beyond that. So let's take one by one these categories. The first we'll speak on is the M0 CRPC. So a little background information. First is let's understand what is this entity M0 CRPC. So M0 CRPC is actually an artificial kind of a clinical scenario. So here is a patient of cancer prostate. Previously, he has been treated already. And then when he was relapsed, that time some ADT has been used. So what have we done? Patient has had some local therapy, either radiation or radical prostatectomy. When PSA started progressing, that time some ADT was already added. And you may have confirmed that the testosterone is at castrate level. Yet we find that PSA is progressing. So this is the condition that we are trying to manage. As yet, on the imaging, there is no metastasis. So as far as we are concerned, this is only a biochemical recurrence. Now what should we do? This is the scenario which we have to think about. Should I treat the patient or should I wait and watch? What should be my thoughts? So what do the guidelines tell us? The first and most important thing is that in this scenario, which is M0 CRPC, all patients do not need therapy. First is to look at how fast is the PSA doubling. So, or how fast is the PSA progression. You calculate the PSA doubling time. You don't have to do it manually. There are many normograms available on the net. And any one of the normograms, if you plug in 2 or 3 PSA recordings by the date, you get the PSA doubling time. So if the doubling time is long, that means if it is more than a year, probably it is safe to wait and watch. You do not need to start therapy right away. However, if the doubling time is short, then it is less than probably 10 months, then yes, you need to start the therapy. So selecting a patient who needs therapy is determined on the speed at which the PSA is progressing. Right. So having now established that this is a patient whose PSA doubling time is less than 10 months, needs treatment, what drugs should I use? In India, we have got only enzalutamide. There are other drugs also which have been approved in this setting, which is apalutamide and darolutamide also. But these are not commonly available. In fact, darolutamide is not available at all. Apalutamide is very, very sparse. So for all practical purposes, we have got enzalutamide. And this is the PROSPER trial, which was the pivotal trial on which this was FDA approved for this scenario. So if you use enzalutamide in this setting, what do you achieve? So this is what it tells us, that in the patient who has had a M0 CRPC, enzalutamide therapy gives him about 3 years free of metastasis. So that means that at least 3 years you will delay the appearance of metastasis. Compared to if you have done nothing, then he would have got about a little more than a year. So inside of a year, he would have developed metastasis if he was on a placebo. But if you use enzalutamide, you pushing back the occurrence of metastasis by about at least 2 years. And similar results are seen also with apalutamide and with darolutamide also. So this is what you achieve, at least 2 years of additional time before the metastasis appears. Now let's come to the second scenario, hormone sensitive prostate cancer, which is metastatic. So the patient has come de novo metastatic. He is hormone sensitive. What do I do in this scenario? Well, there are many drugs available. Abiraterone, Enza, apalutamide, Dosi, which is our standard first-line chemotherapy. And now increasingly we are using Dosi in combination with enzalutamide. But this is not yet the standard of care. So as far as we are concerned, these are the main choices that we have got. All these choices have got a category 1 recommendation both by the NCCN and the EAU guidelines. So you can use any of them. And these are the data which tells us where they have been approved. There are a little bit of nuances here and there. For instance, enzalutamide initially was thought that it would work best in the high volume disease, but then other trials have shown us that enzalutamide works whether the metastasis volume is large or it is a low volume metastasis. Similarly, in docetaxel, we went off thinking from many trials that docetaxel works best if only it is visceral disease or if it is high volume disease. But now data from Stampede and other trials is telling us that no, it's not true. Docetaxel can also be used in low volume disease also. So here is now a question of, with this multitude of drugs available, how do you select? What should I select? So the first thing is to look at the patient fitness. Is he a fit patient to consider chemotherapy, or is he not fit? Then secondly, you look at how rapidly is the double time there, is the PSA doubling time, what is the pattern of mets, is it visceral metastasis, is it high, low volume, visceral, non-visceral? These things you have to keep in mind. Next, you look at the convenience of what you are starting. Third is, because whatever you are going to now start is for long term, you must look at the cost of therapy to the patient and the availability. Because, for instance, now darolutamide is still not available, though it is a good drug, we don't have it in India. And finally, I think the most important part is the patient preference. So many patients, if you start by saying that yes, should be treated with docetaxel, they have a chemotherapy phobia. They may outright refuse to look at chemotherapy because there is a fear of chemotherapy. There is a mental image that chemotherapy means loss of hair, vomiting, patient laid up in bed. And all these things you have to counsel the patient, bring in your medical oncologist in your MDT team, and then the patient will realize that the docetaxel therapy is not as bad as it was believed to be earlier. Okay, so having all these said all these things, I think the other points which have to be considered is the spectrum of the therapy. So if you choose to start ABI or ENZA therapy, this therapy is going to go on indefinitely, at least until the time that PSA progression happens. So you have to bear in mind that this is costly. Abiraterone therapy is almost 10 to 12,000 rupees a month. ENZA therapy is almost 35,000 rupees a month. And every month indefinitely is a big factor to be considered for any patient. On the other side, docetaxel in 6 cycles you're done. In this setting, you do not have to give docetaxel indefinitely. So give 6 cycles, this is a well-tolerated therapy, and you're done with the treatment. So next comes to the next phase of the disease is metastatic CRPC. Now, what are we talking about? This is a patient who has already been treated. He was hormone sensitive. We started all those drugs that I've just discussed, and yet PSA has progressed, and now there is metastasis which is to be controlled. Your PSA is going up. What therapy should I do? The same medicines which we looked at earlier, all those drugs are applicable in this setting. In fact, most of them have first been used in this setting. So, ABI, ENZA, docetaxel. Additionally, you have got now cabazitaxel. Then you have got newer therapies like PARP inhibitors or Pembro, and finally the newer arm which is theranostics. Let's go one by one. So what are we looking at and how should I start therapy? First is to look at what was the prior therapy. Was he started on ABI? Was he started on ENZA? Or was DOSI given at the outset? So all these things you have to look at first. Next is you have to look at how much was the response, what was the nadir of the PSA, how long did that PSA stay unstable, and then you can decide based on these factors your next line of therapy. So question comes on sequencing. Now, what does this mean? So suppose I had a patient who had initially, when he was sensitive, hormone sensitive, and I had given him enzalutamide or I had given him abiraterone, then what should I use? Yes. So should I, if a patient had enzalutamide, should I add abiraterone? Or if he was on abiraterone, should I start with enzalutamide? So these questions have been studied in a few articles earlier. There is only one study which was a prospective study in Lancet in 2019, 202 patients where the sequence was compared. So two groups of patients. First group was abiraterone had been started, and then progression to CRPC, then enza was started. And the second group, where initially enzalutamide was started, and then on progression, AB was introduced. So was there a difference in these two arms? So what did they look at? They looked at the time to progression and how much was the second therapy able to reduce the PSA. So was the significance was 30%. So the second drug should be able to reduce the PSA by at least 30% to be meaningful. What were the results? The results were very interesting. So the first group, which is the patients on abiraterone switched to enzalutamide, their response on the second drug was to the extent of 36%, compared to the second group where initialized on enzalutamide and then switched to AB, that had a poor response, only 4%. And the time that it lasted was 19 months compared to 15 months. So this also translated into a difference in the overall survival of the patients. But it was not a very high significance. So what does it tell us? That the abiraterone enza sequence is far better than the enza abiraterone sequence. Therefore, if we are going to start off with abiraterone therapy or enzalutamide therapy right at the outset, in the first line itself, you have to bear in mind this sequencing concept before we start the therapy. And today you have now level 1 evidence telling us that it's possibly better to start with AB. Now, the best proof of this has come out in the form of a review article, a meta-analysis, and this is as close to level 1 evidence as we can get. So this was published in March 20, and this was the studies which were included. As you can see, in these studies, most of them were between 2016 to 2019. The majority of these patients were from Asia, from Japan. Most, as I mentioned earlier, were retrospective, except the one I just mentioned, that was Khalaf study, which was a prospective study. So on this large meta-analysis also, they confirmed the same points, that the combined progression-free survival, that means that the first line and second line, both combined their progression-free survival. And if you look at the combined PSA response, they were significantly different in the AB-enza versus the enza-AB arm. However, the overall survival is not different. So one may speculate, why has the overall survival not been significant? The answer possibly is that these patients have not been followed up long enough. If you continue to observe them, then probably the overall survival will also be better for those patients who have been AB-enza sequenced rather than in the reverse. So this is the conclusion. AB-enza sequencing is better for progression-free survival, for PSA responses. The response quantum and the duration is better with the AB-enza sequencing, and therefore this is the best sequence so that you achieve the maximum therapeutic benefit at the most economic cost advantage to the patient. So next comes to the question, right? We have done AB, we have done enza, and now patient is progressed again. So I have to introduce a third line therapy. So the question is now what? And again, we were looking at choices, how to select patients. So here is a trial which was published last November, the CAR trial, and that tried to give us answers to what third line should be chosen. Bear in mind, there are some caveats to this study. So let's look at the picture. There were 255 patients in this study. They had been prior treated with docetaxel, and some were either used up abiraterone or enzalutamide, and they had failed early. They had failed within a year. So it was aggressive disease patients who have failed inside of a year. And now they were put into two arms. On one arm, the sequence of the was the reverse of Abi and Enza. What does it mean? So if prior therapy was abiraterone, he was started on enzalutamide, or the reverse. If he was started on enzalutamide earlier, then he was given abiraterone. So this was the first arm, Abi Enza arm. The second arm was cabazitaxel arm. So without trying Abi or Enza, straight away the cabazitaxel was used. And what was looked at was the imaging-based progression-free survival. So was there any more progression on the bone scans or the PSMA PETs? And then the secondary was the endpoints, was overall survival. And these are the curves. As you can see, the PFS was significantly better and separating fairly early in the study on the cabazitaxel arm compared to the Abi-Enza arm. And these are the results. And the subgroup analysis shows that in all parameters, the cabazitaxel arm did better than the Abi-Enza arm, as you can see here. Whether you look at performance status of the patient, time from progression, whether the duration of the progression was early, less than 12 months, or slightly beyond that, age, whether there was visceral mets, whatever Gleason score, whether it was 8 to 10 or below, and so on and so forth. So in all subgroup analysis, the cabazitaxel sequence seemed to work better than the Abi-Enza sequence. So the conclusion from this study is that in the third line setting, for patients who have failed early, who have aggressive disease, then it is better to silently use cabazitaxel than try further lines of Abi or Enza. Of course, there are some caveats of the toxicity of the drug, and the major toxicity was cabazitaxel or with cabazitaxel, hematological toxicity. So about 35% to 38% had hematological toxicity with the cabazitaxel arm. And therefore, you have to give them concurrently GCF in these patients to avoid febrile neutropenia and other complications. This has actually made us think more closely at how are we conceptualizing our treatment. So many studies like some that I have quoted, some meta-analysis like that I have quoted, we are doing actually therapy based on the evidence from trials. But trials is not going to translate into therapy at an individual patient level. So increasingly now we have come to realize that you need genetic studies on the patient's primary or accessible metastatic site to see what is the genetic mutation and then do precision therapy. So that is the only way that you are going to selectively be able to treat the patient with the best available drug suited for him. And that is the way that the therapy of prostate or CRPC is going forward. Now, two therapies in this have actually come to mainstream. The first is Pembrolizumab is now FDA approved in cancer prostate when there is micro and satellite instability on your genomic assay. And the second is PARP inhibitors, olaparib and such other drugs. These have been used where there's a BRCA2 mutation which has been seen. And these are now category 1 recommendations. So I think as clinicians, we have to realize that we cannot just do blind sequencing or sequencing based on these data like what we have just shown, because there are limitations to them. The best way forward is to look at the genetic assays and then use the drugs like these, and more drugs now are coming out in this line. Finally, I'll just add up here this trial, which is the PROFOUND trial, where BRCA2 positive patients were started on olaparib versus on the control arm drugs as per the physician's choice. And this was in fact the first precision medicine trial which demonstrated a significant benefit. Almost 60% of the patients responded very well to olaparib. And mind you, these are patients who have failed multiple lines of therapy. Then genetic sequencing was done. BRCA2 was found, and when olaparib was used, it worked very well. Last point to add now is lutetium. See, lutetium is today coming up as a prominent alternative therapy. Lutetium, as you are aware, is therapy where you are targeting the PSMA avid sites on a PSMA bone scan by giving lutetium tag to a radioligand, which will go and target the metastasis or the primary site and then achieve response. Currently, it is not easily available in India. Only 3 or 4 centers are using it. But now increasingly, there is evidence to tell us that lutetium PSMA PET may be an alternative path to think of in therapy in this difficult setting. So, with that, I'd like to conclude my talk here. And thank you very much for giving me this opportunity. Thank you.